Hello class, and I'm going to do a quick review for the upcoming OB and Pediatric Fisdap exam and some key areas that we need to focus on. Now this review is going to be all things pediatric, of course. When we talk about blunt chest trauma and pulseless extremities, it's related to the peds. It's also going to have obstetrics and gynecological emergencies sprinkled in. So let's get started. Now, when you're talking about assessments of the pediatric population, you are not just talking about small adults. They are inherently different. Let's talk about the assessment first. Now, with the pediatric patient, just as with an adult, the assessment begins at first sight, and you need to think about your NREMT assessment form. And remember that when you arrive on scene and your assessment, you get your general impression when you first see the patient, correct? So the PAT, which is the Pediatric Assessment Triangle, is going to be divided up into those three things: the appearance, circulation, and work of breathing. And don't forget that this assessment begins when you first see the pediatric patient. And this PAT makes it super easy to complete an assessment within 30 seconds, just like as if you are assessing an adult. Okay? I said that pediatrics are not the same as adults. They're not just small adults. All the structures are smaller, can be more easily obstructed, so the airways can be more easily obstructed. Also, compared to adults in shock, pediatric patients stay in compensated shock longer, okay? Their occiput is bigger on the back of their head, and so that's going to cause their neck to naturally, if you're putting them on a flat surface, to kind of kink their airway. So let's get into that. Let's start talking about some different things. Okay, so let's talk about the patho of some blunt chest trauma. Now, because peds are not as developed, their bones are, they say, more bendable or pliable. If you have a younger patient, a pediatric patient who sustained some blunt trauma to the chest, and based on the mechanism of injury, say it was a pretty significant mechanism of injury, understand that you could have minimal external signs. However, the underlying injury can be serious. So you could have a serious internal injury with a minimal external signs. Also, when you're talking about treatment for pulseless extremities, it is exactly like an adult. So once you identify that you have some cool, pale fingers or toes and you can't palpate a pulse, no pulse is palpable, you could pull gentle manual traction. Just make sure it's gentle and it's the exact as the adult. Okay, once we get into spinal immobilization, we need to make sure that we're padding those voids. And I know you've talked about it in labs since class has begun, but we just want to make sure that we are focused on this when it comes to the peds, because the occiput, as I said on slide 2, the occiput area is a lot larger comparatively, and so it will have a tendency to close their airway. Also, if you have like a 14-year-old, 15, 16-year-old, of course, we're going to use a long backboard. Make sure that you are spinally immobilizing them if they're having any tingling or lower back pain, if they've jumped off something. So immobilize them to a long backboard. If you have a 4-year-old, 5, 6-year-old who has a head injury, make sure that you are fully immobilizing these peds. So you also want to make sure that you're placing a towel under that torso area or the scapula area, some type of padding, not too much, but just enough to elevate that scapula area. And also any type of child, a 3, 4, 5-year-old who is in a motor vehicle accident, and you have to secure them to an adult backboard. Make sure, once again, that we are padding under the child's torso. When it comes to toxic ingestion, just make sure that you're transporting these immediately. Of course, we'd probably call poison control. However, if the best answer is going to be transport immediately, that you're doing this. Okay, when it comes to meningitis, febrile seizures, status epilepticus, make sure that you understand the signs and symptoms of meningitis. Now, you have the fever with the stiff neck. So if you have any type of child that is presenting with a fever or lethargy and making grimacing or screaming when the neck is moved around, make sure that you're suspecting meningitis. Now, when it comes to meningitis, of course, we have to make sure that we have on N95s. Once we notice, hopefully you have worn some type of mask or N95 into the area. So you need to immediately put on your respiratory protection in calls like this. When we're talking about febrile seizures, now, if you find a child who's in a postictal state, of course, you need to ensure an open airway. Now, if you have a child, we'll talk about status first. Status epilepticus is when you have a child who is just going into seizures after another, is not regaining consciousness. Now, so if you have a parent who is saying, when you arrive, that this patient has been going 15, 20 minutes from seizure to seizure without waking up, make sure you understand that it's status epilepticus. This is an ALS call, advanced life support, and that they need medication. So you need to get medication to them. When it comes to febrile seizures, remember, it is that abrupt rise in body temperature that is causing this seizure. And so what you want to make sure that you're not doing is really causing some type of abrupt rise or abrupt lowering in these temperatures. Now, it's from a fever. It's very common, so you're going to get a lot of these calls, but it is most often a result of that abrupt rise in body temp. Usually the parents will not have seen this before. They don't know what's happening, so they're going to be a patient as well. Okay, so we'll talk about some abnormal breath sounds or some abnormal airway situations. Of course, before you assess the respiratory adequacy in an unconscious infant or child, you have to ensure that the airway is open and clear of obstructions. Now, when it comes to kids, it is respiratory arrest that causes cardiac arrest. So a lot of these questions that you're going to see are going to be about respiratory situations, but no need to get nervous. Now, kids are normal seesaw breathers. Pediatrics are, so they're going to breathe with their abdominal muscles. And the majority of abnormal respiratory situations are going to come from infections because they're still building up their immune system. So if you have some type of younger child who is restless, has a fever, and the parents are saying that the child is calmer in the steam shower, make sure that you understand, you think croup immediately. Now, croup, of course, is that upper airway, seal-like bark, and it's a stridor upper airway situation, okay? A 4-year-old having difficulty breathing who's drooling and leaning forward. Now, they're going to have a fever as well. This is going to be epiglottitis. Now, this is because that leaf-like structure that is controlling whether air is going in or food is going in, it's that flap is swollen and it's not going to allow any drool to pass through. So they can't swallow. And so they're going to be leaning forward, drooling because they can't swallow. Inserting an oral airway and using a bob syringe. Now, as I mentioned earlier, pediatric airways differ from adults in that all structures are smaller and they can be more easily obstructed. However, you size the OPA as you would an adult. Now, from the corner of the mouth to the angle of the mandible. What is the proper method for suctioning? So when you're suctioning a newborn's airway with a bulb syringe, don't forget to squeeze the bulb before you're placing it into the mouth. Also, you do the mouth first. You have one mouth and two nares. So you do the mouth, then the nose. The newborns are mouth breathers. And if we were to do the nares first, they would, of course, suck in whatever is in the mouth. So respiratory distress and airway obstructions. If you're treating a younger, like a 3-month-old who's apneic, and you're preparing to ventilate the infant, just as if you were going to spinally immobilize them, make sure you're placing a towel under the shoulders or something to prop up, because of that occiput is going to, of course, push their neck into and to cut off the airway. If you have anything in anybody's cheek or airway, if you have a twig or a knife or something that's in the cheek, make sure that you're just checking to see if the airway is patent. And if it is not, you are allowed to remove that object. And then if there is any type of child who is in some type of significant obstruction because of illness. Now, remember, obstructions can be a foreign body. Obstructions can always also be because of illness, swelling. Make sure that you're giving oxygen and getting them to the hospital as fast as you can. Okay, so let's talk about some obstetrics, some abnormal delivery problems, and realize that if you are yanking on the umbilical cord, that you can cause abruptoplacenta. You could cause the placenta to separate from the uterus and bleeding to occur. Also, when we're talking about eclampsia, preeclampsia, understand that preeclampsia is that high blood pressure with swelling, visual disturbances. And then once the seizure starts, that is eclampsia. And so make sure you understand that if you have some type of cord that's wrapped around the baby's neck, that is a nuchal cord, and you have one chance to slide it back over. And if the fetus is in distress before delivery, there is a possibility of a meconium happening, and that's when the fetus has passed a bowel movement inside the actual placenta. Let's talk a little bit more about some abnormal delivery issues or mom problems. Now, I talked on the last slide about abruptoplacenta, and that is when the placenta separates from the uterine wall and it causes pre-birth bleeding. Now, a lot of times this is because of trauma, and the women describe it as a tearing abdominal pain. Now, the vitals are going to be low because of the bleeding, and the mom could be in shock, so she could have diaphoretic skin and pale. So make sure that you expect abruptoplacenta, and it's in the word. It happens abruptly. It's associated with pain and low vital sign, low blood pressures. Also, it can, as I said earlier on the last slide, it could be caused by excessive traction on that umbilical cord during the delivery of the placenta. Now, the next one that has to do with placenta is going to be placenta previa. And I always say, look at the word. It has previa in it. Previous is what I always think of. It's when the placenta is abnormally positioned inside the uterus. It's painless usually, and it's a bright red bleeding in the late in the third trimester. So you should expect the placenta previa if it's painless. Okay, so if somebody is female's in a motor vehicle accident and she's pretty far along, say 34, 35, 36 weeks pregnant, and when you remove her from the vehicle, we want to make sure that we are immobilizing her and tilting her on the backboard. Now, this is because of the supine hypotensive syndrome. If you think about it, right in front of the spinal cord, you have the major vessels that run down. You have the aorta and the vena cava, and it's like a bowling ball is being placed on top of those. And so you're not going to be able to obtain a blood pressure if she is in supine hypotensive syndrome, or it's going to be too low. So make sure that you're tilting the backboards to the left immediately to regain that blood pressure. Okay, so let's talk about some other assessments. Issues or differences. When we talk about getting the pulse in an infant, so 1 year or less, we are taking it in the brachial artery. All right. Also, we could use the fontanelles to help with the assessment indicators. So during assessment, if we see some type of sunken fontanelles, we want to make sure that we're asking about the urine output, or trying to figure out if the baby could be dehydrated. So how many wet diapers the baby has used. Also know that in the 9th month, 10th month, 11th month, 1 year, a gaze should be the baby should be following the parents or tracking the parents with the eyes. And distal circulatory function, a reliable indicator is to push on the fingernail bed to see if the refill comes back, and that's cap refill. Okay? When we start to talk about the abuse indicators, understand that it is it's necessary for us to be able to recognize abuse. And so a scald injury in the lower extremity could be an indicator of abuse. Also, if children are shy and withdrawn, and there are various stages of healings of bruises or injuries, that could be a physical abuse situation as well. And that's a mandatory reporting. Okay, so in conclusion, for the Fisdap obstetrics and pediatric exam, make sure that you understand the pediatric assessment triangle, that assessment begins immediately when you see the patient, that blunt chest trauma could produce serious internal injuries that we cannot see. Don't forget to treat pulseless extremities as you would an adult, that you have one chance to apply gentle traction, spinal immobilization. As with the airway, we're going to make sure that we are placing some type of padding underneath the scapula area or the torso area. Toxic ingestion, we need to get them to the hospital fast. When it comes to meningitis, make sure you're wearing your the correct PPE, which is a mask, not just a mask, but an N95 or a HEPA mask. Febrile seizures are because of the abrupt temperature rise, and normal, abnormal deliveries, placenta previa, understand placenta abrupta, eclampsia. Preeclampsia is when the seizure, eclampsia is when the seizure happens. Preeclampsia is the high blood pressure prior. And croup, epiglottitis, supine hypotensive syndrome, all of those, hopefully you have a better understanding now that you've watched the video. And let me know if you have any questions and I'll answer them. Thank you and good luck on your test.